Hi, everyone. Welcome to today's LACNETS webinar. I'm Lindsay Judavine, the Director of Communications for LACNETS.
And I'm Lisa Yen, the Director of Programs and Outreach for LACNETS.
Before we get started, I'd like to take a second to thank Rich at TVP Live for making today's webinar and high-quality production possible. We'd also like to thank our supporters, Ipsen, Advanced Accelerator Applications, and Novartis. So be sure you're following LACNETS on social media to stay up to date on upcoming webinars and net news. We're on Facebook, Twitter, and Instagram with the handle @LACNETS. Before I pass it off to Lisa, I'd like to remind our viewers that these webinars are done for educational purposes only and do not substitute for medical advice. Please talk to your medical team if you have any questions or concerns about your individual care or treatment. We all have our own opinions, and these are our own opinions. They do not necessarily represent the opinions of LACNETS. And now I'll pass it off to you, Lisa.
Thanks, Lindsay. LACNETS is a program by GeneratePossibility.org, a registered nonprofit, and it stands for the Los Angeles Carcinoid Neuroendocrine Tumor Society. Our mission is to provide education, advocacy, and support for all people impacted by this uncommon disease that used to be known as carcinoid, an old term meaning cancer-like. The more accurate term is neuroendocrine tumor, or NET for short. You'll often hear us say neuroendocrine cancer as it's a patient-friendly way to say the official medical term neuroendocrine neoplasm. We also say neuroendocrine cancer because we understand NET is a type of cancer and not cancer-like or benign as previously thought. While you often see Lindsay and I leading the meetings and programs, we are in fact led by a team which includes our executive director and board member Kavya Velikapudi, and board member Donna Gavin, who's also the sister of LACNETS founder and executive director emeritus Giovanna Joyce Mbesi. Our board also includes Mary Dunleavy, who has been living and thriving with NET for over 17 years. Today, we will hear a story from a patient who is living with NET, someone I happen to know quite well, my husband, Tom, who has been treated, retreated, and retreated with Prrt.
Hi, my name is Tom. I live in Los Angeles with my wife, Lisa. I'm a pianist and composer, and I'm a small business owner. And I'm also living with NET, although that's not my primary identity. I was diagnosed in 2015 with pancreatic NET that had metastasized to my liver. My NET is grade 2, well-differentiated, non-functional. I've had surgery, monthly lanreotide injections most of the last 7 years. I've had a couple radio frequency ablations to my liver, and I've had Prrt. Actually, I've had a total of 8 rounds of Prrt. I had 4 rounds back in 2016 at Excel Diagnostics in Houston. I had another 2 rounds in 2019 at UCLA, and then I just recently finished another 2 rounds at UCLA. So I guess from the patient perspective, I'm very familiar with Prrt. And that's what I want to talk about today. First, I want to say I'm a big fan of Prrt. I've gotten really good results, which have given me stretches of multiple years of stable disease. And I've been able to live a pretty normal life. It's allowed me to spend my time on the things that I find fulfilling and not have to always be thinking about NET. So if you're considering Prrt, you probably have some questions, maybe even some anxieties. I know I did back in 2016. I just didn't know very many people who had ever had Prrt, so I didn't know what to expect. But now I've done it 8 times, so I feel very comfortable with it. So let me just sort of walk you through what the treatment day is like. First of all, you arrive at the treatment center very early in the morning. They start an IV, and you sit in a big, comfortable chair for about 5 hours. Most of that time, the IV is the amino acid mixture, which protects the kidneys, along with some anti-nausea medication. The actual PRT drug, Lutathera, only takes about 30 minutes in the middle of that session. It's actually kind of boring. So I'd recommend bringing something to read. The first time I had PRT in Houston, I did experience some nausea, but I think that was mainly because back then the amino acid mixture that was used is different from what's used now. The last few times, I didn't really experience any nausea at all. And of course, the anti-nausea medication helps. During the part of the infusion where the Lutathera is given, apparently I'm in the minority of patients who report having a mild hormonal response. For about 10 minutes, I feel hot and sweaty and nauseous. And we found that by decreasing the rate of the infusion, we can greatly reduce that. In fact, the last couple of times, I think I hardly noticed it at all. But like I said, it's not something that very many people experience. So I wouldn't worry about that. After the IV is done, the nurse will do a quick check of your radiation level to make sure you're safe to go home. And even that's not very exciting. I like to imagine that I can come home and play with my dog and she'll develop superpowers, but it hasn't happened yet. Actually, from a meter away, my radiation level was only slightly higher than normal. I find that about 24 hours after PRT, I develop mild flu-like symptoms, some nausea, a general achiness all over, mostly fatigue. And then for about 2 weeks, I just feel tired. It's not debilitating, but it does mean that I have to lie down in bed a couple of times throughout the day. That goes away after about 2 weeks. I've found that for me, the side effects are pretty consistent over all the times I've had PRT. So I just block out 2 weeks on my calendar. I tell people that I'm unavailable. For me, it's worth it because then, aside from periodic scans, I don't even need to think about NET for a couple years. And that to me is the biggest benefit of PRT. I mean, having good scan results is great. I don't want to diminish that. But, I'm more than my scan results. And my life now it's just like having my life back. I mean, I get to spend quality time with my wife. Today is our 16th wedding anniversary. We've gotten to travel. We get to eat great food, and I get to work on music. I've released a few albums over the last few years, and I just finished a big music video project, and I'm starting to get ready to record my next album. So life is good. I'm very grateful. If you have questions about PRT, I would just encourage you to talk to your medical team, to reach out to NET experts and NET advocacy groups. And there are a lot of people who have had PRT, like myself, who would be happy to talk to you about it. Wherever you are in your journey with NET, I just want to say there's hope. And I just wish you the best.
I'm pleased to now introduce our featured speaker for today, Dr. Erik Mittra. Dr. Mittra received his medical and graduate training through a joint MD-PhD program at Stony Brook University in New York in 2005. His master's degree was in anatomical sciences and his PhD in biomedical engineering. He then completed a nuclear medicine residency and fellowship at Stanford University and was on faculty in radiology at Stanford for 8 years before moving to the Oregon Health and Science University, or OHSU, in 2018. You may remember hearing Dr. Mittra speak at our first virtual conference back in June 2020. We've invited Dr. Mittra to join us again today to discuss this very popular topic of PRRT, as he is a nationally recognized expert on this topic, which is also called targeted radioisotope therapies. He's very involved in research in this area, in the clinical translation of novel, meaning new radioisotopes for imaging and therapy. He is also very involved in the Society of Nuclear Medicine and Molecular Imaging, SNMMI for short, the LACNETS, or the North American Neuroendocrine Tumor Society, which is a medical professional society for NET, and is the current medical director of the Healing NET Foundation. Welcome, Dr. Mittra. We're very pleased you can join us today.
Hi, everyone, and thank you for attending this talk. My name is Erik Mittra. I'm a nuclear medicine physician and professor of diagnostic radiology at Oregon Health and Science University in Portland, Oregon. And I'm excited to give this talk on the future of PRRT. The outline for the talk is relatively straightforward. We're going to go over the current standard of PRRT so that we're all on the same page, and then we'll dive into the future of PRRT. However, there's many different topics we have to cover in this section on future of PRRT, so let's go ahead and dive in. So with respect to current role of PRRT, again, so that we're all on the same page, it was FDA approved in January of 2018 for patients with somatostatin receptor, that's the SSTR, positive neuroendocrine tumors. It's typically used as second or third line therapy for patients who have metastatic disease, which is inoperable, and specifically for the subtypes of gastroenteropancreatic NETs, often termed GEP-NETs, who are progressing on standard somatostatin analog therapy. In terms of actual clinical practice, we always try to choose patients in a multidisciplinary tumor board setting based on a number of different criteria. First, again, is that NET subtype that I just mentioned, and also making sure that the grade is within the well-differentiated category, which is typically low or intermediate grade. We use the Ki67 index, which is a surrogate for the proliferation marker, and it should be within 1 to 20% for low or intermediate grade. Then, of course, we need to do some imaging. We use PET scanning of somatostatin receptors is required, again, to characterize that these lesions all have somatostatin receptors. And some places will also do FDG PET scanning to make sure that there aren't very high uptake with FDG, which is different than what we're seeing on the somatostatin receptor PET. And then standard conventional imaging with CT or MRI is also needed for full staging and to ensure that everything that we're seeing on the PET scan is the same that we're seeing on anatomic imaging, and also to ensure that typically the patient needs to be progressing on conventional imaging to be eligible for this therapy. We also take into consideration all other factors related to the patient's overall well-being, including what symptoms they're having and other medical conditions. We would definitely consider other therapeutic options that might be appropriate for the patient at that time. And lastly, baseline labs to ensure that the marrow, kidney, and liver function are within limits to be able to tolerate this type of therapy. So this is an example of the somatostatin receptor PET imaging that I was mentioning. It can either be labeled with gallium-68 or copper-64, labeled to Dotate. And this pre-therapy before the PRRT imaging is absolutely required, again, for the eligibility to ensure, as in this patient, that all of the lesions do show high uptake of somatostatin receptors. We also, at our institution and many other institutions, will also do a post-PRRT PET scan with the same agent to see what the response has been. However, this is a little bit more controversial because the specific role of response assessment with somatostatin receptor PET hasn't been as well evaluated. Here, again, the role of conventional imaging with CT or MRI is necessary to really kind of see what the size differences are in these lesions. However, we do dotate PET after the PRRT as well. Another type of imaging that we do, which is even more potentially controversial within the overall field, is the use of lutetium-177 dotate imaging. So lutetium-177, of course, is the actual therapeutic isotope that we're using for the purposes of the therapy, but it also gives off a type of radiation which allows us to take gamma camera images. And so in this example, you can see that we have scanned the patient in this way after every cycle of the therapy, and you can see that there has been a response. So this allows us to quickly get a sense of how well the patient is responding or potentially is not responding to the therapy, and we use this in conjunction with the other laboratory information that we have to ensure that everything is on track for this therapy. However, this is not required by any means, so some institutions will choose to entirely not do it, and other institutions that do it will do it with a variety of different approaches. For instance, we do it 4 hours after the start of the Lutathera administration. Other sites will choose to bring the patient back to do it after 24 hours. And then even the specific manner in which is done, the images that you're seeing here are whole body planar images, but it can also be done with three-dimensional SPECT imaging as well. So there are various different approaches, and there's no standards because, again, this isn't required or regulated. Okay, so the actual therapy itself, as you may be familiar with, is 4 cycles of 200 millicuries of Lutathera given every 2 months. That's the absolute standard, and also what we're limited by the FDA approval and what insurance will typically approve. In addition to that, you can see on this slide the administration of long-acting octreotide. That is, again, an area of somewhat controversy because the NETTER-1 trial that led to the approval of this radiopharmaceutical therapy did use that long-acting octreotide in conjunction with Lutathera, and so many sites feel that that is how the administration should be done. However, there are no randomized studies comparing the use of long-acting octreotide with or without Lutathera. So it's some other sites choose not to administer it unless there are symptoms. Certainly if the patient is having carcinoid symptoms, then it is certainly very helpful to administer the long-acting octreotide immediately after the administration of the Lutathera, and that's the approach that we take. Okay, so to summarize the current rule of Prrt, we're using lutetium-177 as the isotope attached to dotate. This is what was FDA approved in 2018. We administer 200 millicuries for every cycle administered intravenously through your arm vein. We administer 4 cycles of that as long as that's tolerated, and then we give it as typically second-line therapy. Now let's look at where the future of Prrt is going. And literally every one of these different aspects that we are looking at here is an area of research for the future. So first, the isotope is being evaluated by different types of isotopes that potentially might be more efficacious. The peptide is also something that's being looked at as another area of potential improvement. The dose of 200 millicuries, which is standard right now, may not be standard in the future. The route of intravenous administration is also being looked at through intraarterial administration. The 4 cycles of the therapy, which is standard now, may not be standard in the future. And then a large area of research is whether or not to change the sequencing of this therapy or to use it in combination with other types of therapy. And even the indication of well-differentiated low or intermediate grade gastroenteropancreatic neuroendocrine tumors, even that in the future may be something that is done differently. So let's look at each of these different factors in turn. So starting with the isotope. So a real quick basic background on radioactive decay in nuclear medicine. So we use 3 main types of radioactive decay, which are termed alpha, beta, and gamma, very simply. And these are named that way because they were named in the order that they were discovered. And the way this breaks down in terms of imaging and therapy is that alpha particles are very large and therefore very destructive and can only be used for therapy. On the other end of the spectrum are gamma particles, which are essentially packets of energy with no mass. And so they don't interact with matter and therefore can only be used for imaging. So you may hear of gamma imaging, or SPECT imaging is a different term when we do three-dimensional imaging with it. And the beta particles are very interesting because they can either be positively charged or negatively charged. If they're negatively charged, those are beta minus particles. They are our workhorse for most types of therapy that we do, such as with lutetium-177 is a perfect example. And then they can also be positively charged, in which case they're called positrons. And those are only used for imaging. And specifically, that is what allows us to do PET imaging, or positron emission tomography. So when we're talking about PRRT again, traditionally, the first approach was actually with the gamma emitter indium-111. That was found not to be very effective, and so it was quickly abandoned in place of the beta minus therapies, which again, lutetium-177 is the FDA-approved form of that, but yttrium-90 is another beta minus emitter, which has been studied quite extensively, and in Europe and other parts of the world, sometimes that is still used to this day. It has higher energy than lutetium-177, which means that it travels farther in tissue, which can both be good for larger size tumors, but also be a disadvantage in terms of toxicity. But in the future, the main area of focus for novel isotopes is with alpha emitters. The three that are listed there are three common examples of alpha emitters that are being evaluated in different radiopharmaceutical trials. The bottom line, as I alluded to before, is that these are much larger particles. In fact, they're 8,000 times the mass of a beta particle. So really much, much larger. And as a result of that larger size, they may be more effective in causing more damage to the tissues that they're targeting. But also they have a shorter range because they can't travel as far in tissue. You can see that it's quite different, approximately 0.01 millimeters for alpha particles versus anywhere from 3 to 8 millimeters for beta particles. And because they travel less in tissue, therefore they may cause less toxicity. I really want to clarify again that these are the theoretical advantages of alpha particles, and it really needs to be tested in a clinical trial to really know the benefits of that. Here's a schematic that may help you understand this a little bit better. The parent radioisotope is shown at the top, and it's giving off this alpha particle, which again is a very large isotope, which is essentially a helium nucleus. It has 2 neutrons and 2 protons. In comparison to that is the beta particle rearrangements, which essentially lead to either negatively charged electrons shown on the left or positively charged electrons shown on the right, which are again much, much smaller than an alpha particle. This is a different way that may help you understand this. Because alpha particles are so large and so readily interact with matter, even a thin sheet of paper would be enough to stop an alpha particle. A beta particle would easily travel through paper, but would be stopped with aluminum. And then gamma particles and X-rays are lower energy forms of gamma radiation. Those would even travel through aluminum because they have no mass, but would be stopped by thicker lead, such as is found within the walls of our nuclear medicine department and within the doors. So it just gives you a sense of the relative energy and size of these particles. In terms of how we use them for the therapy, the beta particles and the alpha particles are primarily causing DNA damage, and that's what results in their effectiveness. But the beta particles, being much smaller, typically cause single-stranded DNA breaks, whereas the alpha particles cause double-stranded DNA breaks, and that's what allows them to potentially be more effective. So I'll highlight 2 different clinical trials that are ongoing for alpha particles related to PRRT at this time. One is at Excel Diagnostics in Houston. This trial is called Alpha Medics, and this is looking at lead-212 attached to dotate, which is another peptide that binds to somatostatin receptors. And they're looking, this trial is currently open for patients who have somatostatin receptor positive disease, but haven't previously been treated with other types of PRRT, such as with lutetium or yttrium or other radiopharmaceuticals. And then another one is this company that's located in San Diego, California, called Race Bio, and their entire focus is on actinium-225. So they are getting ready to open a multicenter trial of actinium-225 dotate for patients who have previously been treated with Prrt and now are progressing. This will be a multicenter trial, and it's a trial that we will be participating at in OHSU. Okay, the next thing that I'll talk about is the peptide dotate. So the current peptides that are used is shown in the middle column, which is the somatostatin receptor agonists. What that means is that it'll bind to the somatostatin receptor, activate that receptor, and then it internalizes into the cell and then gives off the radiation. But the radiation, since it travels a few millimeters in human tissue anyways, doesn't necessarily have to be internalized within the cell. And the novel agent here is the somatostatin receptor antagonist. So the antagonists bind to the somatostatin receptor, but don't activate it and therefore don't internalize within the cell. However, since they're located on the cell surface, they're still just as effective in terms of the radiation delivery. One that has been looked at and has the greatest amount of research behind it is called LM3. And you can see here in this publication from Dr. Baum's group in Germany, the same patient imaged with the antagonist on the left and the agonist on the right. The middle image is just an FDG scan, so not particularly relevant comparison there. And you can see that in those multiple liver lesions, it's showing up much better with the antagonist because it has a higher binding to the somatostatin receptor than does the agonist. And that's the potential advantage of these new antagonists. And so just as anything would be useful for imaging, if you can see it better, then you can treat it better. And that's what the ultimate benefit of these may be, is that in addition to labeling it with PET imaging agents like gallium-68 shown here, you can also label it with lutetium-177 and then potentially have a therapeutic advantage to the higher binding to the somatostatin receptor. And again, this is being evaluated in clinical trials at this time. The next thing that I'll talk about is the dose. So currently, we're using a fixed dose, as I previously mentioned, of 200 millicuries times 4 cycles for a total of 800 millicuries. We are allowed by the package insert to reduce that to 100 millicuries for 1 cycle if there is toxicity, to allow the body to kind of recover. And if it does, then we return back to the 200 millicuries for the subsequent doses. If the body doesn't recover, then we would have to stop the therapy. However, in the future, there's a lot of focus on personalizing this and changing that standardized dosing approach. So the biggest focus is probably on personalized dose, which makes a lot of sense in theory, because you would imagine that different patients of different sizes with different amounts of tumor and different degrees of uptake of somatostatin analogs would potentially be better treated with a individualized dose rather than a standardized dose. So one way to do this is with post-therapy dosimetry, where we use the initial cycle of 200 millicuries to do post-therapy imaging and calculate then a personalized dose for the subsequent cycle of the therapy. And then we can keep doing that for every cycle of the therapy. You can also potentially do this using pre-therapy dosimetry with a small dose of lutetium-177, or with this novel isotope that's available for dotate PET imaging, which is copper-64, which has a longer half-life. In both of these cases, the difficulty is that dosimetry is not a straightforward thing to do. It requires multiple scans, which is difficult for the patient to come back to the center and do these scans. Also, currently, there's no clear protocol on exactly how to do them. And probably what's most limiting is that it's not entirely clear that even if you did adjust the doses in a personalized fashion, that leads to improved efficacy or decreased toxicity for the patient. Again, these trials need to be done to really prove those things before it can become established. However, this is a large focus within the field of nuclear medicine to try and improve these outcomes. The other way that you might change dose is what's called maintenance therapy, in which you start with kind of more of a standardized approach, perhaps not as high as the full 800 millicuries, and then use a smaller amount, often 100 millicuries is used, to kind of maintain the efficacy of the treatment over a longer period of time. For instance, you may give 150 millicuries for 4 cycles, initially, which is lower than the 200 millicuries for 4 cycles, and then maintain that with 100 millicuries every 6 months for a longer durable response. This is kind of similar to some of the chemotherapy approaches that are used in oncology, for instance. And some sites are doing this and are evaluating it. So that's just one example of how that could be adjusted. Okay, let's look at the route. I mentioned that currently we are only allowed to do intravenous administration through the arm vein. There has been a number of studies that are looking at intra-arterial administration through the hepatic artery to deliver the radiation directly to the liver. And so this would only be beneficial for those patients who have only liver metastases or primarily only liver metastases and very limited systemic disease elsewhere within the body. And so the theory of it makes a lot of sense is why administer it intravenously, because you'll have a lot of systemic circulation and potential toxicity to the bone marrow. Whereas if you deliver it directly to the liver, then you can avoid some of that in theory. This study from UCSF shows 2 patients, A and B, shown there, and it shows actually a little bit of a mixed response. And this is what they found, is that some patients, if you compare the intravenous administration on the left compared to the intra-arterial administration on the right, had higher uptake, such as patient A, which is what you would expect, but other patients actually had lower uptake, such as patient B on the bottom. And so this particular approach is not entirely known right now, and I would say that the preliminary data is a little bit mixed, but again, in theory, it does make a lot of sense to try this approach. Okay, looking at the number of cycles, again, we're currently limited to a maximum of 4 cycles, both by the package insert and, as I mentioned, by what insurance companies will approve. But again, in the future, this can be adjusted. The main way that people are thinking about potentially changing this, which makes a lot of sense, is if the patient initially did very well with the initial 4 cycles of Prt, and have a durable response, meaning at least 12 months before they start progressing, ideally even 18 months or longer, then instead of moving on to a different type of therapy, why not simply repeat Prt once again over 4 cycles, or perhaps a few less cycles, 2 or 3 cycles, but again, try to get that same type of benefit. So this is sometimes referred to as salvage Prt or simply repeat Prt. And we're definitely evaluating this now in the US just in a clinical sense, because many of those patients who were treated initially in 2018 and 2019 are now at that point that they would benefit from additional cycles of therapy potentially. And I do know that several sites within the US are having success in terms of insurance coverage of repeat Prt, but there are also some challenges there as well. So we're kind of figuring this out in real time. The clinical trials that have been done on this concept basically show that there is a benefit to doing repeat Prt on those patients, again, who had a good response initially, although the effect of that response tends to be a little bit less than what was initially seen, which I think makes sense whenever you're repeating the same type of therapy all over again. And then the other ways to adjust the number of cycles would be that instead of adjusting the actual dose per cycle that I mentioned previously with personalized dosimetry, instead, you might just still give 200 millicuries, but adjust the total cumulative dose of that, either decrease from 800 millicuries or increase from 800 millicuries based on what the patient can best tolerate. And again, that approach of induction followed by maintenance therapy is another example ultimately of changing the number of cycles as well. Okay, now let's look at sequencing and combination. So currently we, as mentioned, are doing just 2nd or 3rd line. We're typically using it as a monotherapy, plus or minus with the somatostatin analogs, as was mentioned, especially for patients who have symptoms. But in the future, there's a huge number of different ways that this is being looked at. So let's look at these in turn. First, in terms of sequencing the therapy, the biggest approach or focus currently in terms of clinical trials is moving it to an earlier time point than later on, because we know or we expect that treating with Prt earlier would potentially be more effective than waiting until the disease has progressed. So there are several studies looking at this as first-line therapy, and even as neoadjuvant therapy. What that means is prior to initial surgery for patients who may have more bulky disease. Can you use PRRT to kind of decrease the tumor burden and therefore make the surgery more effective? That's neoadjuvant setting. So that's probably one of the more interesting ways that the sequencing approach is being looked at. Another large area of research is on combination therapies with some of the other agents that are available. So two examples that are probably of the greatest focus is combining it with capecitabine and temozolomide, because those agents may actually act as radiosensitizers and therefore may make the effect of the lutetium-177 better than if you actually used it alone. And then PARP inhibitors are another area of study because they also cause DNA damage. So since lutetium-177 and other radioisotopes are also causing DNA damage, maybe the combination of the two will be even more effective than using one of them alone. Liver-directed therapies such as chemoembolization and bland embolization, potentially even radioembolization, are things that are used for patients, again, who have liver-dominant disease. And it's currently not known whether it's better to do liver-directed therapies first, followed by PRRT, or the reverse, or potentially even to use them in conjunction with each other for the greatest efficacy. So there are several studies that are ongoing in terms of looking at that type of sequencing and also in terms of the safety. External beam radiation isn't used too commonly for patients with neuroendocrine tumor, often because patients have many sites of disease, and external beam radiation is particularly useful for only a few sites of disease. However, this is another thing that needs to be evaluated through trials, is what is the potential benefit of using these in combination with each other. One interesting article that was published along these lines that I just wanted to bring your attention to was from the group at Vanderbilt University led by Dr. Das, where they looked at, in a retrospective fashion, whether they could identify upfront which types of features about a patient would help to predict which patients would benefit from this PRRT and which patients would not benefit from the PRRT. So what they did was look at a number of different features about the patient, such as what their symptoms were, how much disease did they have, what other therapies would they be eligible for, whether they had diffuse disease within the abdomen called carcinomatosis, and what therapies did they already have received. And so they scored this using a 3-point scale, 0, 1, and 2 for each of these different features, and essentially looked at what the outcomes were from the PRRT that they subsequently got. Now, this is a Kaplan-Meier curve, which is a very common way to depict the data from these types of trials in oncology. And essentially what it's showing, I know this is a busy slide, but essentially what it's showing is those patients who had a lower score, so had less burden of disease, had been less pre-treated with prior therapies, etc. Those are the ones that did better than the ones that had a higher clinical score. And also those that were able to tolerate more cycles of the PRRT did better than those who were treated with less cycles of PRRT or received other types of therapy. So this is an interesting publication. It suggests that using this type of a clinical score can predict the response, which is, again, as I mentioned before, something that we essentially guessed before, but this is useful to actually have real-world data to support that hypothesis. It's suggesting that earlier treatment is more effective, and which is why it would be helpful to potentially move PRRT earlier in the treatment sequencing. It also had some sub-analyses, and one that I found very interesting was that those patients who had prior liver-directed therapies didn't have different outcomes from PRRT compared to those that did not. So as I mentioned, the sequencing of the liver-directed therapies versus PRRT is unknown at this time, and this retrospective analysis suggests that it doesn't really matter which one you do first. This study certainly has several limitations. One of the biggest ones is that it is a retrospective cohort study, meaning a specific group of patients that they looked at. And so all of these outcomes ultimately need to be validated in prospective randomized trials, some of which are ongoing at this time. Okay, and then lastly, let's look at this indications. I mentioned that this is approved currently for well-differentiated grade 1 or grade 2 gastroenteropancreatic neuroendocrine tumors. Well, what about in the future? So one is that perhaps we can start using this outside of gastroenteropancreatic and look at other subtypes such as lung or renal neuroendocrine tumors, or even things like pheochromocytoma and paraganglioma. And then the other is that instead of being limited to the low or intermediate grade tumors, there are several large clinical trials ongoing right now looking at well-differentiated grade 3 tumors. So again, using the Ki-67 value, the AAA's NETTER-2 study includes patients with up to Ki-67 of 55%, as does the ITM's COMPOSE trial as well. So both of these very large multi-center trials are actually including well-differentiated grade 3 tumors. And I mentioned earlier on at the very outset that FDG PET, in terms of glucose metabolism, may also have a role in patient selection. And there are some trials looking at what true effect that has on in terms of patient selection and outcomes as well. Okay, so let's look at the examples of pheochromocytoma and paraganglioma. At our institution, what we'll do is for these patients, we like to image both with MIBG and with Dotate. So MIBG is the type of imaging that would then allow for treatment with an MIBG analog labeled to iodine 131, which is has the brand name Azedra. And then we also have, of course, the Deuterated Imaging for Prrt. In this particular patient example, they have similar uptake on both of these agents. They're not going to look identical because the MIBG is labeled with a gamma emitter, whereas the Dotate is labeled with a positron emitter, which has higher resolution. That's why the Dotate images look sharper than the MIBG images. But accounting for that, they essentially have very similar uptake. This second patient, however, is a stark contrast to that, where the MIBG scan is actually negative and the Dotate scan is very positive. So how this would then relate to the treatment choice is that the patient one, since they have very similar uptake, we would go ahead and treat with the MIBG analog or Azedra, because that is what is FDA approved for pheochromocytoma and paraganglioma. Whereas the patient on the right, we would treat with Dotate or Lutathera, even though it's off-label, because we can see the uptake on the scan, and so therefore they would have better outcomes with that than with the MIBG, where there's no uptake at all. And we have had good success in getting Lutathera approved for these patients based on this kind of data. Here's a different patient, which kind of summarizes how this all happens in the real world. They were diagnosed with metastatic pheochromocytoma in January of 2021. They come from a community location, and so the only access to imaging they had was with the glucose analog FDG. And so on this scan, FDG PET scan, you can see that there are multiple areas of uptake corresponding to the sites of metastases, mostly in the bone, but there was also some lymph node disease as well. So then they were referred to our institution. And again, the first thing that we did was with both Dotate imaging, showing very similar uptake on the FDG PET scan, perhaps a little bit brighter. Also, Dotate has lower background uptake, so that's also why it's looking a little sharper. And we also did the MIBG scan as well. This is another example of a patient that has very similar uptake on Dotate and MIBG. So because of that, we went ahead and treated with Azedra, because that's, again, the clinically FDA approved indication. So we treated 2 cycles is the way that's therapy is typically given every 3 months. So we treated in May and August of last year. And then they returned back to their community setting, and just last month got a FDG PET scan to follow up. And you can see that comparing the initial FDG PET scan to the recent FDG PET scan, there's been a complete response to the treatment, which is really wonderful. And also the patient's metanephrine values also returned back to normal as well. Okay, so in summary, we've covered a lot of ground, but again, the current FDA-approved label for Prt, as I hope you've now seen, is just a start. Literally every aspect of the current PRT regimen is being evaluated in different clinical trials, including the radioisotope, especially with a focus on alpha therapy. Also, the specific somatostatin analog peptide is being looked at with these new antagonists, such as LM3. The route of administration is being looked at. There's a large amount of research going on in terms of the dose and the number of cycles, especially with the use of patient-specific dosimetry. There's also a lot of research going on in terms of the sequencing of these therapies and the combination with other types of available therapies. And lastly, but not least, the other types of NET subtypes and grades of NETs is also being looked at in large clinical trials as well. So in the future, I think there's a lot of different ways that we're going to adjust the use of PRT beyond the standardized approach that is currently being used. So with that, I thank you for your attention, and we'll lead into the discussion. Thank you.
Thank you, Dr. Mittra, for this really great presentation. What an excellent overview on the future of PRT. We're so glad to have you here today with us for this Q&A.
Thank you so much, Lisa, for having me here, and thanks to all the people who are listening and remotely. Really appreciate it.
It's really exciting, and what a, like I said, what a really great overview. It's really exciting to hear that this is just the start. The current PRT is just the start, and it's like the tip of the iceberg, and there's so much more work being done. And thank you for all your work on that. And I just wanted to remind the viewers that this program is for educational purposes only. I know we've said this already. It's not a substitute for medical advice, and we encourage you to talk to your medical team about your specific case and questions. Also, while we do our best to answer as many questions as possible, may not be possible to get to all the questions and your specific questions. So feel free to reach out to us, or there's other programs as well that you could submit your questions. So with that, let's get started, because there's a lot of questions that have rolled in. So we're going to start with some questions, well, with side effects, because that's kind of the current PRT things. And I know there are people now who are undergoing PRT and experiencing these side effects. So is it unusual to have severe pain after a PRT treatment, especially if you have significant bone metastasis?
Yes, I would say it's very unusual to have severe pain, actually any pain at all. We've treated a number of patients who have quite extensive bony metastases, including the one image that I showed at the beginning of the Dotate PET scan. And it's very, very rare for those patients to experience significant pain. More rarely, I would say, sometimes pain does occur in patients who have significant liver metastases and already have kind of a baseline of pain potentially, and the inflammation from the radiation can sometimes exacerbate that slightly, but even that's not very common.
So what would you suggest if someone's having significant pain?
If they are having pain related to it, then it would be normal pain management type of things, so opioids or other medications. Hopefully, if it does also happen, even if it's unusual, then it tends to be kind of just transient for a shorter period of time, and then would hopefully pass.
Okay, that's helpful. And some people talk about being fatigued. Why are some patients fatigued for a very long time after PRT treatments?
So this is another side effect which is actually not very common at all. I would say the vast majority of the patients that I've treated end up perhaps having some fatigue, even then mild for a few days after the treatment, and then it sort of goes away. But I am aware of this being a little bit more common than the pain that we just talked about. And as far as why, that's very difficult to answer. I think this is like a lot of things in medicine where we chalk it up to different differences in how people kind of respond to these different therapies. So there's no specific way to predict this, but it does happen to some degree. Again, luckily though, very uncommon. Hopefully, here, if it's very prolonged, all I can say is that once the 4 cycles are done, then the fatigue should go away.
Okay. Yeah, and I think along those lines, I guess part of the question is how long would they be experiencing the those types of symptoms. So this person is currently approaching their third PRT treatment and still feels sick every day. So is that considered normal? I think there was a related question is, are they expected to feel better before their next treatment?
Yeah, I think when it comes to side effects with not just PRT, but with a lot of different things, again, we do definitely know from a lot of the evidence that we have had in the prior trials about what is normal in the sense of what is common, but I would not therefore lump together uncommon things as being abnormal. And I think the two things that we just talked about in terms of fatigue and pain, hair loss is another one that's sometimes been mentioned, or I should say hair thinning. These are all very uncommon, but if it does happen to you within the course of the PRT, I wouldn't get too worried about it because different people react differently to these different things. And again, even the duration is quite variable. Most people, like I say, when they experience these things, it's transient. It'll happen um, for a short period after each cycle of the PRT, and then go away, and then usually will happen again after the next cycles of the PRT. In very unusual situations, it lasts throughout the whole period of the 4 cycles of the PRT. But any of the above, I would say is okay. It's not abnormal. Everyone just responds differently. I think the key factors that we look for in terms of being able to continue the therapy are the laboratory values, which we want to make sure that is not dropping below too far, and then the imaging that I showed you to make sure that there isn't any evidence of progression. These other side effects, it's certainly not pleasant, but we want to try to get through the whole therapy, and then I think these will go away afterwards.
That's really reassuring. And for the person who submitted the question, we hope you feel better soon. So there was a lot that you covered with different repeating PRT and different types of PRT. So one question that came up, and there's other questions around this: when's a subsequent round of PRT contraindicated?
I feel like there's probably about 3 answers to that question. The main one that I actually just referenced was we're constantly worried about labs, and so we're checking those on a routine basis after every cycle of the therapy. Many people, though, may wonder about the timing of those labs, and I will say that it's quite variable. Some people or some institutions tend to be very conservative with their labs and will only check it right before the next cycle of the therapy to make sure that everything is on track. We do it halfway between the cycles of the therapy, and then we do additional labs if there is some issues with that. And then other places might take a more conservative approach and actually check labs even more frequently. I know that some places like to check labs 2 weeks after each cycle of the therapy and then continue that throughout the period. So that's probably the number one thing if your laboratory values, and the main ones we're worried about is your bone marrow toxicity. So that would mean things like your platelet count is probably the leading one, but also it could potentially affect your white cells or your red cells. If those drop below a certain amount, we do expect it to drop to some degree and then recover by the next time of the next cycle. But if it drops too far, then we might have to postpone the next cycle of the therapy to allow your body to have a greater chance to recover. The other approach that we take is to reduce the dose of that next cycle of the therapy by half, again, to allow your body to recover. If both of those approaches still don't allow your body to recover appropriately, then that would be a reason why the next cycle would subsequently be terminated. The other ones are less common, I would say, but if some of these side effects that we're talking about, for instance, become too significant to the point that it's not just transient, it's not just something that you can tolerate, then that would be a reason to potentially stop the treatment because it's causing essentially more harm than good. And then the third would be, and this is again a little bit variable depending on institutions, but some places will do imaging between the cycles of the therapy. Most common is between the second or third cycle of the therapy, sometimes between the third and fourth. And if they see clear evidence of progression, or even on the lutetium whole body planar scans that I showed, if there's clear evidence of progression on any imaging during the course of the therapy, then that would probably be at least a reason to pause and consider whether continuing with this therapy makes sense or it doesn't. But many places, and we're one of them, don't on purpose do any significant imaging with either PET or CT or MR, specifically because we want to avoid any chances of a false positive finding on that study that would preclude getting the additional cycles of the therapy, which may actually be helping, but we're kind of thrown off by some, images which are confusing.
Yeah. Well, thank you for that really thorough response. And this actually kind of touches on someone else's question that they're nearing their third lutetium 177 treatment, and they're monitoring the blood work, but nothing else. So why aren't the gallium dotate scans or other tests done during treatments?
Wow, that question couldn't have been more perfectly worded relative to what I was just saying. Yeah, so blood work is a standard throughout for everyone. We absolutely need to make sure that it's not causing too much bone marrow toxicity, so that will always happen. But right, as I mentioned, any other additional type of imaging or evaluation is optional, I would say. It just depends on the comfort level of your treating physicians, of the institutional practices that they have, and so forth. I don't think there's necessarily a right or a wrong way to approach that. The question specifically is asking about gallium PET scans, and of all the imaging tests that could be done, that's probably the one that definitely shouldn't be done. And the reason for that is that even after all 4 cycles of the therapy are done, and you're for sure at that point trying to evaluate what the response to that treatment has been, even in that very clear setting, the use of a gallium PET scan actually hasn't been entirely validated, because we don't know entirely what changes in SUV uptake on that scan necessarily mean. We definitely know what changes in size mean. For the most part, if things are getting smaller, that's great. If things are stable, that's also good. If things are getting bigger, that's generally speaking not bad, of some very minor exceptions to that rule. But gallium PET scans are much more in evaluation right now. So of all things, that's why I would definitely say it should not be done during the course of the treatment.
Yeah, thank you for that. Thanks for that. Let's talk a little bit about indications and when to use PRT. Is the current PRT less effective for large liver tumors? And if so, what form of PRT in theory are best to treat large size tumors in the liver?
Generally speaking, the larger the size of any lesion, what this is specifically asking about liver lesions, but it could be anything within the body, are, I would say, yes, less effectively treated with radiation. And the reason for that is that the delivery of the PRT given through the arm vein is all based on blood supply, as you may imagine. So if there isn't good blood supply to all the parts of the tumor, and the larger the tumor gets, especially the central components of that tend to have poor blood supply, then equally the radiation won't be delivered to those areas, and therefore you can easily imagine that it won't have as much effect. Now, this is not to say that kind of moderate sized tumors which have good blood supply, those are still fine, but I'm talking about the larger lesions which become more necrotic within the center. So that's a general true statement. And then specifically for the liver, the benefit is that there are these specific liver-directed therapies that I alluded to, including chemoembolization, radioembolization, and bland embolization. These also depend on the blood supply, but they work not by delivering the radiation, but by kind of blocking the remainder of the blood supply to the outside of those tumors. So if there are large size liver lesions in particular, then those would probably be, and this is a very general statement, again, it depends on your specific situation, but my guess would be that those might be generally better treated with liver-directed therapies than with PRRT. But yes, there are many unknowns to this. We would have to look at the PET scan and see what the distribution of the uptake is throughout those liver lesions. We'd have to look at the blood supply from the hepatic artery and see what that looks like, and kind of compare everything and choose the best modality.
There's not a simple answer.
No.
And, this is an interesting question. Can brain tumors be treated with PRT, even if remaining tumors no longer light up due to radiation treatments? And I'm just also wondering if brain tumors can be treated with PRT. And also, the second part, what about tumors that don't light up in general?
Right. You're right, Lisa. This is a question kind of combines multiple different questions into one, actually. So to start with the brain tumor part of it itself, so brain metastasis from neuroendocrine tumor does happen, but it's not very common. But in those situations where it is there and it does show high somatostatin receptor expression on the PET scan, many places have treated those patients, and they actually tend to do well without any significant side effects from the radiation delivery to the brain. So, as a general statement, again, all my statements are general because it's very hard to make specific recommendations without knowing more about your case. But in generally speaking, that is something that can be done. The other side to it is what about the tumors that are no longer lighting up? So if the lesions are not showing high somatostatin receptor expression, again, as a general rule, that's not a good candidate for PRT because it just what doesn't light up on a PET scan, similarly, won't have a lot of delivery of the PRT when we administer the therapeutic agent. There are some patients that may have some heterogeneity in their lesions where some still retain high expression of tumors and then others don't. Those patients are definitely something that we have to very carefully discuss in the neuroendocrine tumor board, because the real question becomes not about treating the remaining areas that are showing uptake, because those would be treated by the PRRT, but why are the remainder of the lesions no longer showing expression? And if they, for instance, change to a higher grade of tumor, or simply no longer taking up somatostatin, then since they won't be treated by the PRT, maybe PRT at that point overall as a systemic treatment isn't the best option, and you might want to separately treat the brain metastasis in that case with a different type of treatment that's more localized, potentially external beam radiation as an example, and then use some other type of systemic therapy for the other lesions which aren't lighting up. So that becomes a much more complicated scenario. But the general answers there are that you can potentially treat brain tumors, and lesions that no longer light up should not be treated with PRT.
Thank you for that. Thanks for that. What about Merkel net carcinoma? Is PRT good for Merkel net carcinoma?
Merkel cell carcinoma is a skin cancer, which is also considered a variant of neuroendocrine tumor. It certainly can metastasize to lots of places within the body, just like any other type of neuroendocrine tumor or any other type of carcinoma can. There is some very preliminary studies because of that association between neuroendocrine that are evaluating the role of PRRT for patients like this. At this point, it's very, very early. All I can really say is that there are some case reports which are suggestive that in those patients where the PET scan really shows a high expression of somatostatin receptors, that there have been some anecdotal good responses. And there is, I believe, a trial at Excel Diagnostics currently, which is taking all types of neuroendocrine tumors, which are not gastroenteropancreatic neuroendocrine in origin. And so we may have some more data on this in the future. Certainly makes sense in theory, but I think it's very early to really know what the results will show.
Thanks for that. Well, let's move on to some of the questions about repeating PRT and the combination and all these future things in the works. Can you have more than 4 treatments in a lifetime, meaning PRT treatments? Is there a lifetime maximum?
Yes, this depends if you ask an insurance company or if you ask a medical doctor. So I think, again, this is a complicated scenario because there's a few different factors that we need to consider. Just as a general statement, in theory, no, there's no specific hard and fast rule for those 4 treatments. And that was how this NETTER-1 study was designed. That was how a lot of the earlier, even phase 1 and phase 2 studies were designed, which led to the NETTER-1 study being designed that way. So there's a lot of history as to why there were these 4 cycles of treatment. And it's kind of almost an established standard in nuclear medicine, I would say. But like I say, that doesn't necessarily mean that every patient needs all 4 cycles of the treatment. You may actually need less than that. And what the question is really getting to is if you did well with those 4 cycles of the treatment, why not potentially continue it on to get an even more added treatment, either right away, such as a 5th or 6th cycle, 2 months afterwards, and so forth, or this repeat PRRT idea where you do the 4 cycles of the treatment initially, stop, see what the degree of progression free time is, and if it's a good period, either 12 or 18 months, then consider repeating multiple cycles of the therapy again subsequently every 2 months. So those are kind of the 2 different approaches. Certainly, there has been a fair number of research articles that have looked at both those approaches, and the results, generally speaking, are, to summarize very broadly, that yes, the efficacy does appear to be good or better if you can continue the cycles of treatment in patients who did well with it initially. And the second part to that that's very important is the toxicity getting worse or changing now that you're giving additional cycles of therapy? And it turns out, it generally speaking, does not. So the preliminary data here is generally favorable for it. Going back to the insurance concern, so in the United States, we're limited by getting everything pre-approved through private insurance companies. Medicare does not do pre-authorization. We only find out subsequently whether they will pay us or not. But in either scenario, the guidelines all only talk about those 4 cycles of the therapy. Right now, we are in the United States kind of right at the juncture of being able to figure out whether we are able to do repeat PRT, because many of those patients who were initially treated back in 2018 when this was approved had a really good response, but are now progressing, are exactly those patients where we would like to repeat the PRT. So I think in terms of the repeat PRT, we're going to find out very soon whether or not insurance companies are, generally speaking, approving this or not. Also keep in mind that those types of things change over time. So as an insurance company also kind of gets more data and learns about these things, and we're finding that these repeat patients are doing well, as the earlier studies showed, then perhaps, and I hope so, that they will, change some of their policies and approve a good therapy that works for that patient, as opposed to forcing them to move on to a different therapy that, may or may not work for that patient. But as far as the increasing to 5 or 6 cycles over the course, that's, I believe, a little bit farther down the line. I talked about dosimetry. I don't know if there's any questions on that, but those are the kind of things that might change once we have more dosimetry protocols in place, because I can't imagine that some patients would benefit from that, but we wouldn't feel comfortable to do that unless we have some data to support it.
Yeah. Thank you for that thorough answer, and really, kind of weighing in what's theoretical and also realistic with insurance. And I'm just curious also, because you said, that now you're kind of dealing with it real world with those people who are needing repeat treatments. What is your experience with dealing with insurance companies, and what has the success been, or what have you heard out there?
Yeah, so in our own institution, we've had the good or bad luck, I don't know, that all the patients that we've been wanting to do retreatment on have all been have Medicare insurance, and so as I mentioned, they don't do pre-authorization. So the approach that we took, which might be interesting for people to know, is that we actually had to go to our hospital leadership to get this approved, because there's a chance, like I say, Medicare will either pay us in the end or they won't. So we won't know until we've already done it whether or not the insurance will pay us. So we had to get approval from hospital finance that we could potentially have this liability. But they actually did approve it, and so we are moving forward with that, and so we'll see. In other institutions, though, I have heard that several groups have moved forward to do PRT and have received some pre-authorization. So again, very early data, but I think that there's some promising information there.
Great, thank you for sharing that. That's hopeful. So I know you've already kind of touched on this, but this person asks, if you completed all 4 rounds of PRT with only moderate success of tumor control, would a second round stand a chance of being more successful?
I would say probably not. And the answer to that is coming from several of the trials that I mentioned that did look at this idea of repeat or salvage PRT and how effective that was. And even in those patients that were pre-selected as having a good response initially, as I mentioned, that's at least 12 months of progression-free survival or 18 months ideally, depending on which study design it was. What they routinely found is that the effectiveness of the therapy was less than the first go around, although it was still quite good compared to potentially other treatments that the patient had had prior to that. And so while it's promising, as a general rule, I think it's fair to say that when you're repeating PRT or probably pretty much any therapy, that the second time you use it, it's going to have a less of a good response than the first time it did. So in this question, if the first time was already only a moderate success, then I would think that it's going to be even less successful.
Thank you for that. And if grade 2 metastatic liver tumors remain unchanged, is PRT warranted for a second round if they start growing again? And if so, is there a time frame on when? So, I mean, I think especially this time frame question, whether it's grade 2, grade 1, liver tumors, others, what is the time frame for repeating PRT?
Yeah, so I think this is ultimately getting at similar to what we've been discussing so far. So it seems to be saying that based on the first cycles of PRT, that they've had a good response and the liver tumors are more or less stable. Yeah, I think the main answer to this, again, probably goes back to this 12 to 18 month time frame. If the liver tumors are growing before 12 months and yeah, even potentially 18 months, but definitely before 12 months, then most people would say that repeating PRT is not a good idea because that was too soon for them to have progressed. And so it's not considered a very durable, good response from the initial cycles. But if it's beyond 12 months and certainly beyond 18 months, then that would be the time to restart PRT. The only caveat to that, of course, is it's probably a given, but you would need to repeat the PET scan, Dotate PET scan as well to confirm that those same liver lesions and all the other lesions throughout the body still remain with high expression of the somatostatin, because it can change over time. But as long as those things are still fine and done, then you can repeat PRT.
Great, thank you for that. And, again, with repeating PRT, how does a second round of PRT compare to other systemic treatments, like the IV treatments for widespread tumor load?
Yeah. Oh, sorry. One additional thought before we move on to this question for the prior question is that since they were specifically asking about liver tumors, I just want to again throw in that there are other options for liver dominant disease, specifically such as the various liver embolization procedures. So if that patient was being presented in our tumor board, that's the discussion we would probably have. Is that even if they did have a good response to the PRT, have they or have they not previously had liver-directed therapies done already? Because if they haven't, then that's also very very good efficacy from that as well. Again, for liver dominant disease, so you might want to kind of alternate those two and do that as the next round, see what efficacy you get from then. And then again, you can always repeat the PET scan in the future, see what you're working with in terms of the somatostatin receptor expression, and do PRT in the future, knowing that it's a good option for that patient. So that's a good example of kind of the discussions that we have in the tumor board to decide, because we don't want to, especially if PRT has been very successful for you, we don't necessarily want to pull the trigger on that too soon, again, because we want to save it when it can be effective again.
Good point. Thank you for that.
Yeah, so for this question about second round of PRT compared to other systemic treatments, really, I think it kind of depends. It's a little bit too broad to answer. I think it depends on what the primary tumor is, where the degree of metastases are, what other systemic therapies have already been tried potentially prior to PRRT, etc. So it's very hard to give a general answer to that. But those are the types of questions that we would discuss in the neuroendocrine board to answer this specific question. The general statement that again I keep making is that it keeps going back to that degree of response based on the first 4 cycles of the therapy has to be in the range of 12 to 18 months at the very least. If that is the case, and the patient doesn't have too many other options for other systemic therapies, or perhaps they've tried other things and either didn't tolerate it or the response wasn't very good, then that's when we would consider repeat PRRT.
Thank you. Thank you for that. So you brought up the RaiseBio study that has not opened yet, that will be opening. If you're currently getting PRT treatment, are you eligible for the RaiseBio trial? Or would you have to finish PRT and wait until you have progression?
The latter, yeah. The way the RaiseBio study is designed, that it follows lutetium-based PRRT as the first line of treatment, which makes sense. This is essentially how all of these kind of novel radiopharmaceutical trials are designed, and frankly, most chemotherapy trials are designed, is that you would have to go through what is already FDA approved, and only once that's done, then would you be eligible for that trial. So that's the first answer to that question. The second part to that, though, is that because alpha particles are known to be much more destructive, I should say, to the DNA. I won't say necessarily more effective, because that's what the point of the trial is to determine. But since it's known to be more destructive than the single-stranded DNA breaks that the lutetium causes, it also kind of makes sense from a scientific standpoint to wait until you've already completed that, because it doesn't necessarily make a lot of sense to jump to the biggest guns, but rather to do what's FDA approved and what's known to work based on a phase 3 trial. Once you've completed that and then you are looking for the next treatment, then I think that study could potentially be a really good one. And that's exactly how we're hoping to use it for us, and why we're excited to open it, because again, we're in that realm of many patients needing kind of the next post-PRRT treatment, and we're not sure about what's happening with insurance carriers and so forth in terms of repeat PRRT. So this would be a perfect option for those patients who can't get repeat PRRT. It is a randomized trial of alpha PRRT compared to best standard of care. So that's something to keep in mind. That getting on the trial doesn't automatically guarantee that you're going to get the alpha PRRT. So some patients who may specifically want another type of therapy or may want repeat PRRT with lutetium may actually want to opt out of that trial.
And what will the standard of care arm be?
It could be any of the other systemic agents like everolimus or Kip-Tem.
Okay.
Or liver-directed therapies.
Yeah, thank you for that. And that point, right? What that you said, completing what's FDA approved and then possibly moving on. It just gives us an insight to how you may be thinking about it as you're going in discussions with the tumor board and with the patients.
Right.
Here's another PRT question. Is alpha PRT a game changer as far as dosimetry is concerned for liver mets? Is direct therapy to the liver arteries going to create less renal burden?
So I feel like it's asking potentially two different questions. So let me take each one in turn. So the alpha PRRT, is it a game changer in terms of how much radiation gets delivered? And again, this is asking specifically to liver mets, but keep in mind it would be delivered through the arm vein intravenously, just like lutetium PRRT goes, and so it would go everywhere there is somatostatin receptor expressions, whether in the liver or outside of it. I wouldn't exactly use the word game changer as far as dosimetry, because that's a very specific term in terms of how much radiation dose gets delivered, which actually I don't know off the top of my head what the comparison is between lutetium versus alpha PRRT. But the game changer aspect of it is what I mentioned a few times, is the degree of DNA damage that amount of radiation can cause. So even if it's a similar amount of effective radiation, the type of radiation is very, very different, because this is such a larger radioactive isotope that is causing double-stranded DNA breaks as opposed to single-stranded DNA breaks. And that's where the real game-changing aspect of it can potentially be. The other game-changing aspect of it, again related to the size, is that it'll interact with those cells immediately around where it was delivered, where the somatostatin receptor is. And so it's not going to go very far within tissue. And when that happens, it causes less toxicity to surrounding tissue and to the bone marrow and so forth. Those are the two main sort of game-changing aspects that why people are really excited about alpha therapies in terms of the dosimetry and in terms of the true effectiveness of that greater degree of damage. That is what the clinical trial needs to show. It's very hard to predict what that will be. There is a lot of information from PSMA for prostate cancer nowadays in our field, and if we take some lessons from there, it does look like the efficacy of alpha therapy is also quite high. So that's why I think a lot of people are very excited about this, but ultimately the clinical trial has to show it. As far as the second part of that question is, I think that's true in theory. The only caveat to that I would say is that we aren't super worried about renal burden to begin with, especially with the use of amino acids causing good renal protection. We generally speaking see very little renal toxicity. For those patients who do have poor renal function or baseline renal function, or other issues that might be affecting renal toxicity, such as other medications that you might be on, for those patients, I think that is a theoretical benefit to delivering it directly through the hepatic artery.
Thank you for that. And it may be too early to know since the trial is not open yet, but do you know when the RACE bio trial will be complete and when we will know the results?
I can just give the timeline that the trial is about to start in some centers in the US as we speak. And it's kind of designed as a early phase 1 trial, then moving on to a phase 3 trial later on this year. At our institution at OHSU will probably start later this summer, I think. That's just the initial recruitment. It'll probably recruit for 1 to 2 years, and then we'll have to see the net effect of that after that, because of course we have to wait for some outcome information from that trial. So I think it's going to be probably 2 to 3 years at a minimum before we'll start seeing some preliminary data from that.
Okay, fingers crossed. And talking about studies, is the objective of the PRT combination trials more DNA strand damage in the tumors or increasing the sensitivities of the tumors to take up the lutetium?
Yes, the answer to that is both. So I mentioned that there's two main sort of agents that are being looked at for these combination trials, and I think both of them are potentially very exciting. One is the combination of capecitabine and temozolomide, which are commonly used for pancreatic nets or for lower intermediate GEP-nets in general. Those are thought to potentially cause a radiosensitizing effect, and so therefore basically make the lutetium more effective than it already is. So that is the sensitivity part to it. And the other one is the PARP inhibitors that I mentioned. PARP inhibitors cause DNA damage by preventing the DNA repair mechanism. Lutetium and alpha therapies cause DNA damage by actively destroying the DNA. And so you can easily see how the combination of those two things could potentially have a synergistic effect and improve the efficacy. So we'll have to ultimately see what those trials show, but I would say both of those types of trials could be potentially exciting. And the other thing to keep in mind, of course, whenever you're combining these different types of agents that I didn't exactly focus on, but also to make sure that the toxicity isn't also increasing, because every type of agent that we use has its own toxicity profile. So it's great if it improves the efficacy, but we also have to make sure that it doesn't make the toxicity too much.
Great. Thank you so much. And I know we just have a couple minutes left, so we'll end on, this one or one more question after this. Of the numerous PRT combination trials now underway, which of these are you most interested in, and which do you believe holds the most promise?
So my real answer to this question is all of the above. And the reason why I say that is because it's so easy sometimes to just kind of jump on, one or two key things that seem to be very exciting. And I know that there's a lot of interest in alpha therapies or combination therapies are probably the two that maybe most people jump on, but you never really know, what the end result of those trials are going to be. And some of the other things, on the other hand, for instance, dosimetry comes to mind. maybe some of those other peptides come to mind that don't seem to garner as much excitement may in the end actually be the ones that really are the main things to look at. So whether, I'm speaking to funding agencies that are trying to fund these trials, or to patients as I am now who are focused on these different trials to enter, I would try to be kind of cautious in terms of like diving in too soon to a specific area before we have any actual data to show from them. And that's the whole point of clinical trials and the scientific method and so forth. And so, yeah, I'm personally excited across the board to see all these different changes that are going to be happening with PRRT over the next 5 to 10 years.
Great. Thank you so much. And kind of a follow-up with that, with all the current trials open now or on the horizon. I mean, you mentioned the different isotopes, the combination, and also the possibility of repeating them, and alpha. How do you decide on which one's best for your patient?
Yeah, so I think it's a perfect follow-up question to what I was just saying. So exactly, again, not to just hone in on just one or two trials as being the only ones that are potentially of value and everything else is not. I would honestly say that all these trials need to be done. Specifically for deciding between them, there's so many different factors. It depends, number one, on the eligibility criteria. Each of these clinical trials have very, very strict eligibility criteria, and sometimes these criteria are so strict that even us on the medical side don't necessarily agree with all of them, but they are what they are, and we have to follow their guidance very strictly. And then in terms of availability as well, you want to go to something that you can. There's a lot of requirements for these trials, and so you want to make sure that you can attend to all of those study requirements as needed, what's available to you locally. So definitely talk to your primary oncologist about what the different trial options are, and then look into those different things, and they'll help kind of manage and guide you towards your best options. Ultimately, we all want the best outcomes for you, and so all these are just different options of ways to get there.
What a beautiful sentiment. Ultimately, you want the best outcomes for us. So with that, I guess we'll just, invite you to share some closing comments, remarks, what you might be most hopeful for in the future, or any words that you want to leave the audience with.
To say that I really love interacting with patients, and especially in the neuroendocrine community, because they're so engaged and they're so thoughtful, and every time it's a real pleasure. So thank you so much for inviting me to give this talk and to be able to answer some of your questions. I know we weren't able to get to everything, but just definitely remain hopeful, because as I've hopefully shown you, there's a lot of excitement in our field, and this is all translates to you in terms of all these different things that are going on. So I think we're going to see a lot of exciting things in the future. So thank you.
Thank you for giving us reasons to hope, and we just look forward to hearing more in the future. Back to you in the studio, Rich.
This LACNETS program is made possible by supporters like you. Every year, LACNETS reaches more than 10,000 patients and caregivers around the world. Our monthly webinars, annual conferences, podcasts, support groups, and many other programs we bring to the NET community are not possible without the generosity of our donors. Your support can make a powerful difference as we continue to support those affected by neuroendocrine cancer. Visit us at lacnets.org/donate to learn more about the ways you can support LACNETS.
Be sure you're following LACNETS on social media. We have Facebook, Twitter, and Instagram. Stay up to date on upcoming webinars and NET news. Now I'll pass it back to you, Lisa, to close us out.
Thank you, Lindsay. We offer many programs and resources, including our weekly NET support group, a dedicated caregiver-only support group, NET Vitals, which is a downloadable patient-physician communication tool to help you prepare for your medical appointments, and health coaching. We encourage you to go to our website, lacnets.org, to find out more information about our programs, view resources, read blogs, take NET quizzes, and much, much more. LACNETS now has a podcast featuring local NET experts who answer the top 10 questions in their field. We release one episode every month, so stay tuned for more. Thank you again, Dr. Mittra, for your educational and helpful topic. To many of us, myself included, this topic is personal to us, and we are deeply grateful for all your dedication and all you do for the NET cancer community. Thank you to Rich at TVP Live and for all of you for joining us today. Goodbye and see you next month.